today I'm going to be discussing psychedelic-assisted therapy in adolescent contexts. And if you were expecting me to give the advocate talk where I start with the rates of adolescent depression and what an important intervention this could be, I'm sorry to disappoint. Like that whole conversation is much more than half an hour. What's motivating this talk is these trials, I think, are a near inevitability for reasons that we can perhaps discuss after the talk. So instead of, yeah, let's give kids drugs, it's more, okay, if this is what we're going to do, let's start to talk about what can we do to really optimize the risk-benefit profile here. It's a mishmash of some scientific stuff, some ethical stuff, some clinical stuff. The clinically oriented bits were developed with a friend and colleague, Dr. Bryony Insua-Summerhays, who could not be here. So I will do my best to try and regurgitate that in my own words. But apologies to you and to Bryony if I mess that up. Okay, so this is where I'm going to take you over the next 25 minutes. I'm going to start by taking you back to the 1960s. To fetch and dust off a concept called the matrix, developed by an early researcher and therapist, Betty Eisner. Nowadays, you only really get references and explicit discussion of the matrix in some sociology of psychedelic articles, but I really think reintroducing this concept to our scientific, to our clinical thinking can be quite helpful. I think it's something that will be helpful, whatever the population under discussion, but for reasons I will go into, particularly germane for adolescents. Then en route to my wider point, we're going to spend a few moments thinking about the travails of a mouse that will hopefully be obvious by the time we get to it, and if it's not obvious, it should be by the end. At that point, I'm going to cash in any winnings, like I will present to you the kind of mild milquetoast Diet Coke versions of what I think we can draw from this. And if you're still nodding along by that point, I'm crediting myself with a win already at that point. And then we're going into stranger waters. So I will then begin grinding another axe of mine, which is related but distinct on the value of psychological formulation in psychedelic trials. This is something I anticipate will be par for the course when these interventions are licensed, but having spoken to people running trials, it's very much non-standard for good reasons at the moment. But if we're going to push forward to trials with adolescents, the need to optimize the risk-benefit ratio for that vulnerable population trumps those reasons. And then we will conclude with a kind of far-out one that's more attention-grabbing. And if you don't follow me all the way there, that's fine. So I actually have a little bit of trepidation today in introducing or reintroducing the matrix on account of where it comes from, its originator. So Betty Eisner was one of the first LSD therapists, and like many of the first research and therapists of that generation, she is a figure not without significant controversy. To the best of my understanding, she really caused a lot of harm to a number of people under her care and ended up losing her license over it. And I don't want to shy away from that, but I just want to clarify before we go on, this is an endorsement of an idea of hers, which I think we can reconstruct from things we've learned outside of psychedelic science since the 1960s, rather than a broader comment or legitimization of Eisner. Right, so first off, what is the matrix? It is incredibly intuitive to understand. It was proposed by Eisner as a third extra pharmacological factor that can influence outcomes in psychedelic therapy. And simply put, it's just the environment that a patient is coming from and the environment that they return to after they've done the trial. So why do I think the matrix is important? I'm increasingly thinking matrix is important for adolescent contexts, but really I think we might be sleeping on it in the field as a whole. Yeah, so there's lots in psychedelic therapy that we still don't have plenty of evidence for. There's still a lot of variance in what's going on in the outcomes. And we're not really tracking matrix factors at all, and I think we should. Right, and so there's no direct evidence for this because, as I said, we're just not attending to this at the moment. But I'd like to spend a few moments to convince you that this isn't a mad hunch or a whim. So the first reason I think the matrix is important in psychedelic interventions is because it fits hand in glove with the biopsychosocial model of mental health, mental pathology, the idea that mental distress, mental illness arises because of the interaction between your biological system, but also what's going on psychologically and socially. And I think whatever mental health intervention you're thinking about, like it's a worthwhile investment to think about the environment that people are coming from. Say you're doing your 8-hour CBT course through the NHS. Yeah, you might be having 1 hour of therapy each week, but you have 100 other waking hours which are surely impacting what's going on for you in terms of your mental health otherwise. Like if I told you someone took a 1 hour run every Sunday, and I asked you if that person's living a healthy lifestyle or not, that's just not enough information before you know what the hell are they doing in the other 100 waking hours that they've got going on. And the final reason I think this is going to be relevant for psychedelic therapy, is because it's relevant and well replicated across all sorts of other interventions. We know that there are factors in your social ecological environment that make a difference to the progression, resolution of mental health issues. So things like your family, your household dynamics, like the availability and depth and strength of the social support that's available to you. Also, to add to that, we have that most cherished of properties of psychedelics, the fact that they are plasticity enhancers. You know, taking psychedelics makes it easier to remold, reshape the patterns of thought and behavior that can contribute to distress. And yeah, it's often spoken that this is one of the reasons why psychedelic therapy works so well. And when we talk more casually about plasticity, we treat it as if it's just an unalloyed therapeutic asset, that it's just a good thing. But of course, plasticity, being more liable to be molded, is an opportunity for change, but it's valence neutral. It's going to really matter what is the environmental input on that person when they're in a state of plasticity. And finally, you can discount this if you want, because arguably this is just my confirmation bias from reading the literature, but there are plenty of clues littered around the literature that suggest that the matrix is important. I've only got time and space for 2 of these. So in the Challenging Psychedelic Experiences project, of a study population of people who had extended difficulties, one of the most highly endorsed sources of benefit or relief from those difficulties are social in nature, things like talking and feeling heard, and acceptance and validation. And of course, these are the sorts of things that you would expect to be getting in your integration sessions, right? But as we know, integration is not 1 or 2 1-hour sessions. It is a long, protracted process that carries on whether you're in the clinic room or not. And then in Imperial's first trial of treatment-resistant depression, they found that patients who did not have strong support from family or friends described feeling vulnerable and alienated afterwards. So the matrix, I think, plays something of a dual role. Potentially, it's a source of support for processing, for integrating your psychedelic experience. But it's also an environment that can either be reinforcing or challenging the insights, the changes that come about when you have a psychedelic experience. And before I jump into why I think it matters more in adolescent psychedelic therapy, let's spare a thought for this mouse. So if there are any behavioural pharmacologists in the room, this is fingers in your ears time because I gloss over a little bit of nuance. But the reason why I present this slide is, well, one reason that we were originally confident that SSRIs have antidepressant action is because if you give a mouse SSRIs and then hang it by its tail on a peg, it will struggle and wriggle for longer trying to get off the peg. Like, it's a test of active and passive responses to a stressful situation. And like, I totally endorse like wriggling off the peg for longer, like exerting effort against your environment to improve your situation. Like, that is a good thing. Like, I think when you're depressed, ultimately, whatever treatments you're getting, there's a large part of the immune response that comes from you and like your engagement with the environment. I will point out, however, that this mouse who has been given an SSRI, you can't tell with that one, yeah, will be wriggling longer than his brothers and sisters who haven't been given an SSRI, but it's of no use to that mouse, right? That mouse like could struggle and struggle and struggle, and it won't get off that peg, like, because it's in a situation that it can't escape from. And that's no shame on the mouse. It's just that it's in an environment that it's not within its power to change. And usual disclaimer, I'm not ragging on SSRIs. Like, they're very good functional aid. They can help you like develop the changes you need at a cognitive behavioral level, or whatever your preferred model of psychological change is. But I would stress, if your story of depression starts and ends with the biological system, you are ignoring the reality that very often the biological systems are responding to their broader environment. After the picture of the mouse, I realized that maybe I could have made this slide a bit more visually engaging, because if you're only going to pay attention to one slide, it's this one. This is the one I want you taking away with. It's just 2 facts about psychedelics and adolescents. The first one is something that I've said before, like a couple of slides ago. Like, psychedelics can enhance environmental sensitivity. That's not all that plasticity or enhanced plasticity means, but it's certainly a component of it. And the other thing about adolescents, and especially about legal minors, and what you need to bear in mind with them is that compared to a typical adult, compared to anyone in the room here, your typical 15, 16, 17-year-old has considerably less agency, considerably less autonomy to change their environment. So like, clinical ethicists have made a good, sincere effort over the last 40 years to try and honour and extend the agency and autonomy that under 18s have. But let's be frank, if you are 15, 16, you have very little control over your environment compared to us. Like, what do you have to do most days? Well, you're subject to the rules of schooling. There is some flexibility in that, but realistically not very much. Like, during your adolescence, you're spending more time with your friends, you're forming this social identity, but a lot of your time is spent with your family. And if you don't like school, if it's a source of stress, if you don't like your family, if it's a source of distress, there's practically very little that you can do. And so, to kind of condense down one of my anxieties about adolescent psychedelic therapy, it's in this question, like, what value is it to make someone more environmentally sensitive? Like, if they're in an environment that's made them depressed and they've got relatively little agency to change it. Like, if you read the like adult psychedelic literature, especially the qualitative stuff, it's replete with these examples of people, well, to some extent it's behavioral activation, but it's like engaging with your life, making changes, like altering the environment so that you get better in various ways. And I have reservations about how easily that will translate across to a 15-year-old. Right, so practically, materially, what am I worried about? Well, best case scenario, you have an adolescent taking a psychedelic therapy and is returning to an environment where maybe their parents aren't well informed. Their parents aren't well equipped to deal with the integration to support them through that process. And maybe you just miss out on optimizing the benefits. It might be that you get that very welcome, wonderful, immediate relief from your symptoms and things look good. But if nothing in the environment has changed, it's plausible that those same pressures that developed into depression beforehand just reassert themselves eventually. And like the worst case scenario would be that you've given someone a psychedelic, given an adolescent a psychedelic, and they're in this plastic state, and they're actually more influenced to the same environmental factors that could have contributed to their distress in the first place. All right, Diet Coke conclusions. Hopefully you'll nod along to at least one of these things. Yeah, we should be really paying attention to what sort of environment our prospective 15, 16, 17-year-old trial participants are coming from, what they're going to return to. And I think the safety of the container is of particular importance for under 18s. So a really salient pattern over my PhD interviews with adult participants is how important it is to have your partner or your carer or someone close in your life really being able and willing to be with you through that. And it's fairly non-controversial, I think, to say that a 15-year-old who doesn't have a reliable support network at home isn't going to be a good candidate for psychedelic therapy. So I'd invite us to consider maybe if we're going to run these trials, like we don't run the intake on a particular patient, we're really thinking about the families, like are they coming from returning to a family that is well suited to help them through the post-psychedelic stage, or preferably so we're not just excluding people wholesale, can we help the families to provide the support that they need? Right, okay, I'm going to move forward now, and regrettably I'm going to have to take you back to the 1960s, to the last time that we were trying psychedelics with under 18s. This great review by Sigafus about 20 years ago now really succinctly described the research program of LSD for autistic children, which was basically, well, nothing else has worked, so why not try LSD? And I would really argue against that logic for experimental treatments with children, legal children and adolescents, in the case of psychopathology. Right, so let's consider treatment-resistant depression, which plausibly could be the first intended indication for this population. Okay, so Johnny comes to the clinic. He's 17. He's been depressed for maybe 2.5 years. Like he's tried 3 antidepressants, hasn't really had any success from them. No obvious childhood adversity. Both his parents come, they seem very supportive. Like there doesn't seem to be any reason why he's depressed. You know, maybe he's a good candidate for psychedelic therapy. I think if a 15, 16, 17-year-old is getting no relief from 3 antidepressant treatments, there's a very good reason why that isn't happening. And if they're failing with 4 SSRIs or what have you treatments, like there is something that is not being understood there. Like what needs to happen is for us to have an account of why aren't these things working, rather than just trying new things, like really take a step back on what's going on. In other words, what you need is psychological formulation. I'm mindful, I'm running a bit off the pace, so I will go quite quickly on this. Formulation, if you don't know, it's what you'll get if you begin like a psychological therapy process. It's the why to the what of diagnosis. Like it's not what is your mental health issue, but what's happened to you? Why have you come to be this way? Like, what are the factors that have precipitated? What's perpetuating? What's potentially protective in your environment about these things? With the idea being that if you can zone in on the factors in someone's life that are causing this, those are plausible clinical intervention points. And quite how formulation happens will vary according to your preferred modality. I think for teenagers, still living at home, there's lots to be said for systemic therapies, things like, well, family therapy, systemic therapy. What I like about systemic therapies, especially in the context of adolescents, is that there's this central core idea that when someone comes, say, with depression to the clinic, they're the identified patient, right? It might be that this is where we can see the distress and the dysfunction, but that's not necessarily the whole story, and it's just an issue with them. Like, the presenting patient is an emissary for the wider family system and is carrying like the distress and the pathology that's residing in the system, like maybe like in their parent who hasn't resolved their own shit, like maybe in the ways that people are relating to each other in the complex dyads and dynamics throughout the system. Yeah, an important thing to recognize, like when an adolescent is presenting like with distress, like deeply depressed, is they're an adolescent, right? Like in a family system, it's very plausible. This is the person with the least life experience, the least agency to sort of healthily express their distress. Like, their teenagers are bad at mentalization. They're not really good at articulating these things. Yeah, and they've got the least agency to affect the necessary change. So why is Johnny depressed? So the following won't be true for all teenagers with depression by any means, but it is true for Johnny because I invented him and I know his backstory. Right. And part of it is a reason about adolescent mental health that I've not really discussed yet, and that's just simply the fact that adolescence is hard. Like, you don't need to have had serious adversity, like you don't need to be going through something distressing right now, but the process of going from being a child to being an adult is difficult. Like the intrapsychic, the interpersonal tasks that you have to fulfill to get to being an adult, like developing agency, developing your social identity, individuating from your parents, becoming your own person, those are complicated and distressing, like regardless. Is that my 5? All right. Yeah, so it could be the case that like Johnny is stuck in these tasks. Say he's trying to like bridge out and become independent, and he's experiencing conflicts either internally or perhaps externally from one or both of his parents. Like perhaps he's got a rigid, cut-off dad who is leading him to be shut down. So a thing that's important to understand about family systems, and this is true of your family system too, whether you recognize it or not, it's true of most family systems, whether they are healthy or otherwise, is that they tend towards homeostasis. Like we fall into the same emotional and relational patterns with our siblings, with our parents, and a lot of the time that's fine, and sometimes it can cause distress in one or more parties. Yeah, so maybe what Johnny is doing is a developmentally very normal task of like seeking more independence and autonomy, and one or both of his parents are pushing back against this because it's distressing to them for whatever reason, like threatening family stability. And rather than rocking the boat with doing this again and again, like these acts of independence that trigger conflict or trigger like anxiety, Johnny is shutting down into a depressive state because that's adaptive for him in that moment there, because that's preferable. And funnily enough, when Johnny is depressed and shut down and withdrawn, just so turns out that he's more dependent and like less independent, and that's a way that the homeostasis is maintained. Like, so now you know a bit more about Johnny. It's not just that, oh, he's tried 3 antidepressants and he's failed. Maybe we could give him psychedelics. To knowing this backstory, knowing what's going on for him, and recognizing, should you give Johnny psychedelic therapy, knowing what you know now? Well, you could, but once he's out of that clinic room, like the tasks are still the same, the potential for conflict is still the same, and yeah, you might get a little boost in the days and weeks after psychedelics, but if there's been no shift in the rest of the system, like when he goes back into these normal development, like seeking autonomy, if it's the same response, well, this is like the environment pushing him back into the same way. All right. And now we reach the kind of full fat, the spicy take, which is, if we're going to consider adolescent psychedelic therapy, maybe one way that we should be thinking about doing this is psychedelic-assisted family therapy. And by this, I don't mean let's get everyone in the room and have them trip and it'll work itself out. By God, I do not mean that. What I mean is, what needs to happen is, let's get everyone in this family system together, and talk and develop a family formulation, let the clinician figure out what's going on by talking to the family as a group, talking to them individually, talking to particular dyads, the siblings, the parents, the dad and Johnny, what have you, and get a sense of where is this dysfunction being generated in this system. And to be clear, that question, where is the dysfunction being generated, is distinct from where is this distinction, where is this dysfunction being manifested in Johnny, right? Just because Johnny is the depressed one doesn't necessarily mean Johnny's what we've got to fix. Instead we can ask, where is it that the change needs to come? And there's not going to be a cookie cutter answer for this. Sorry for the pretension of quoting Tolstoy, but in Anna Karenina, it said, happy families are all alike, unhappy families are each unhappy in their own way. But when you've got a family in, you can get a sense of what are the rhythms and dynamics between all the members and ask this question. What is going to be a most helpful intervention point? And maybe dad being rigid and cut off. In some cases, maybe it is dad that needs to trip. All right, I'm going to rush through the last of it. And then after someone has tripped, you can ask a question that's going to vary on a case-by-case basis. Should there be family-based integration work or individual? If it's Johnny that takes the trip, and sometimes it will be him, is what Johnny needs afterwards space away from his parents to kind of grow and develop in his own way. Sometimes it will be that. And sometimes, the integration, the post-psychedelic work, should be in family and doing family work. I've called this the radical conclusion, but there's a precedent for it already. Rick Doblin spoke about it on Wednesday. MAPS have been giving MGMA to couples therapies where only one of them has PTSD. And this is a proof of concept that you can improve clinical outcomes in the identified presenting patient by pharmacologically intervening on one of the other ones. I am going to skip that and say thank you for your attention.